Hello, sir. Good evening, sir. Sir, Namachayam, sir. இருக்கீங்களா, sir? Good evening, sir.
சார் ஒரு 5 மினிட்ஸ்ல சார் வந்துருவார் சார். குட் ஈவினிங் சார். பிரசாந்த் சார்.
ஓகே.
அதோ சார் வந்துட்டு இருக்காரு சார். சரி, தேங்க்யூ
சார். ஹரிவரசன் சார், குட் ஈவினிங் சார்.
குட் ஈவினிங் சார். குட் ஈவினிங் சார்.
நான் டாக்டர் முத்துமணி சார். கேக்குது சார், கேக்குது சார். நல்லா இருக்கீங்களா சார்?
நல்லா இருக்கேன் சார்.
சார், டாக்டர் தினகர் சார் லைன்ல இருக்காரா சார்? வந்துட்டாரா சார்?
வந்துட்டார் சார், அவரும் இருக்காரு.
சார், சார் குட் ஈவினிங் சார்.
ஹாய் சார், ஹாய் சார், ஹாய் சார்.
முத்துமணி சார், நல்லா இருக்கீங்களா சார்?
நல்லா இருக்கு சார், நல்லா இருக்கு சார்.
உங்க ரெண்டு பேரும் இப்பதான் பாக்குறேன் சார் நானு.
ஆர்கே சொல்லிருக்காரு சார், உங்களுக்கு சொல்லிருக்காரு.
அப்படியா சார்? என்ன சொன்னாரு, நான் அப்புறம் தனியா சொல்லுங்க சார்.
இல்ல, ஜஸ்ட் கேஷுவல் டாக் சார்.
ஓ, சரிங்க சார். சார் ஒரு 5 மினிட்ஸ் சார். நமச்சிவாயம் சார் வந்துட்டோம் சார். ஸ்டார்ட் பண்ணிடுவோம் சார்.
வைரல் ஃப்ளூ எல்லாம் எப்படி சார் போயிட்டு இருக்கு? குறைஞ்சிருச்சா
சார்? கொஞ்சம் குறைஞ்ச மாதிரி தான் இருக்கு சார். இந்த வீக் கொஞ்சம் கேஸ் கம்மியா இருக்க மாதிரி இருக்கு சார்.
ஓகே ஓகே.
கொஞ்சம் ஃபீவர் இன்சிடென்ட்ஸுமே ஜெனரலா கொஞ்சம் ஓபில எல்லாமே கொஞ்சம் கொஞ்சம் கம்மியாயிட்டு இருக்கு சார்.
குறைஞ்சிருக்கு. ஓகே.
ஆமா சார்.
நீங்க பிராக்டிஸ் இங்கேயா சார், இல்ல ஊர்ல? எங்க சார் ஊர்? லால்குடி தானே?
லால்குடி சார். லால்குடியில சார்.
ஓகே ஓகே ஓகே. இங்க முடிச்சுட்டு அங்க போயிருவீங்க?
ஆமா சார்.
ஓகே.
மகேஷ் ரெடியா இருக்கியா
சார்? குட் ஈவினிங் சார்.
மகேஷ் ரெடியா இருக்குல்ல?
ரெடியா இருக்கு சார். சார் குட் ஈவினிங் டு எவரிவன் சார்.
குட் ஈவினிங் சார். வரட்டும், நமச்சிவாயம் சார் வந்த உடனே ஸ்டார்ட் பண்ணிடுவோம்.
ஓகே சார், தேங்க்யூ சார்.
Dr. Muthumani, good evening.
சார் குட் ஈவினிங் சார்.
டாக்டர் ராதாகிருஷ்ணன் ஜாயின் பண்ணீங்களா? அவர் ஜாயின் பண்ணிட்டு
சார் அவரு கொஞ்சம் லேட்டா வருவார் சார். மீதி 2 கேஸ்ட்ரோஎன்டராலஜிஸ்ட் இருக்காங்க சார். டாக்டர் ஹரிவரசன், டாக்டர் தினகர் மணி 2 பேரும் வந்திருக்காங்க சார்.
Shall we start the presentation?
ஸ்டார்ட் பண்ணிடலாம் சார். ஸ்டார்ட் பண்ணிடலாம் சார்.
எஸ்.
நமச்சிவாயம் சார் ஜாயின் பண்ணிட்டாரு இல்லீங்களா?
சார் வந்துட்டாரு சார். சார் ஜஸ்ட் வராரு.
ஓகே. குட் ஈவினிங் சார். நமச்சிவாயம் சார்.
Good evening, sir. Good evening, sir.
Good evening, sir.
Yeah.
Good evening, sir. Good evening, sir.
Good evening.
Good evening, sir.
Good evening. Yeah.
Sir, good evening, sir. Good evening, sir.
Good evening. I am Dr.
Good evening,
Saravanan
sir.
from Coimbatore speaking. Yeah. Okay. Yeah.
Yes, sir. Yes, sir.
Good evening to each and every one of you. Really my pleasure to welcome you all for this week postgraduate teaching program of API. We have pleasure of having the very knowledgeable professor of medicine from KPV, Trichy Medical College. Dr. Namachivayam sir is with us, and we have an eminent gastroenterologist from Trichy. Dr. Radhakrishnan is going to join. He is from a senior assistant professor from KPV. Whereas Dr. Arivarasan, consultant gastroenterologist from Kaveri Hospital, Trichy, and Dr. Dinegar Mani is also consultant gastroenterologist from Trichy Kaveri Hospital. Really, I should thank all the gastroenterologists and really appreciate the gastroenterologist interest in this teaching program. Really appreciate your interest also. So now we have Dr. Ajaram Magesh, is the postgraduate from KAPV, is going to present the case of abdomen case. Over to Dr. Ajaram Magesh.
Sir, good evening, sir.
Good evening.
Good evening. Sir, I am going to present a case of massive splenomegaly. Sir, a 45-year-old male, name XYZ, occupation labor by occupation, residing in residing district. Hello, sir.
Go ahead, go ahead, go ahead.
Sir, a 45-year-old male, name XYZ, labor by occupation, residing in Karur district, came admitted on 19/9/22. Date of examination was 29/22. His chief complaints were abdominal pain since 3 months, decreased food intake since 3 months, loss of weight since 3 months, abdominal swelling for 2 months, exertional dyspnea for 45 days, both lower limb swelling for 15 days, easy fatigability for 15 days. History of present illness. Patient apparently normal 3 months back, then he developed pain of 3 months duration, which was insidious in onset. Site left hypochondrium. It is a intermittent dull aching type, non-radiating, no aggravating factors. It was associated with nausea and decreased food intake during pain, which was relieved on medication. A patient had loss of weight about 5 kgs, which he noticed during early onset of symptoms. There is abdominal swelling, history of abdominal swelling since 2 months, which was insidious in onset in the left abdominal region. Patient noticed a localized swelling initially in left hypochondrium, then it gradually increased in size, progressed towards progressed to downwards and medially to umbilicus, and then up to right iliac fossa, and attained to present size, which was with no positional changes. Initially, it is not associated with any leg swelling or breathlessness.
What would be the cause for abdominal pain in a patient with, you're presenting an abdominal case, no? What are the various causes for abdominal pain in a patient with presenting as an abdominal case as a postgraduate?
Sir, acute abdomen might be appendicitis. Seen in appendicitis.
You don't say surgical causes. You should talk about only medical causes.
Peritonitis.
Again, you want to go for surgical cause, medical cause. Can you give peptic ulcer disease? Pancreatitis?
Acute gastritis.
Don't say acute gastritis. You're a postgraduate. Peptic ulcer disease.
Peptic ulcer disease, GERD, gastroesophageal reflux disease.
Pancreatitis.
Acute pancreatitis.
Then what? Diabetic ketoacidosis. Get abdominal pain, no? Diabetic ketoacidosis, you get severe abdominal pain. Then cholelithiasis, gallstone. Any diffuse atherosclerosis where you can have eccentric artery occlusion, atherosclerosis, all this could be the medical causes for abdominal pain. But your pain is more on the right side, left side.
Yes, sir. Left hypochondrium.
Left hypochondrium. So what do you think it should be?
Sir?
What do you think it should be? The pain should be?
Pain due to...
All the pain is in the left hypochondrium. What could be the cause of pain in the left hypochondrium?
Splenomegaly.
Splenomegaly.
Pancreatitis.
So why do you get pain in splenomegaly?
So splenomegaly due to overstretching of capsules. Stretching of capsule induces pain in splenomegaly. And splenic infarct, splenic hemorrhage.
Splenic hemorrhage. You want to be a surgeon after taking MD, do MD-MS. Any splenic capsules?
Splenic abscess, splenic hematoma can also induce pain, sir.
Sorry, proceed. So you should analyze what should be the is it coming from any gut lumen or from a solid organ? This pain you said no, dull aching. Where it is coming from?
So it's coming from solid organ, sir.
If it is from the lumen, what will happen? What will be the nature of the pain?
So it will be colicky type of pain.
Colicky type of pain. So it is a dull aching pain, not colicky type of pain. Yes or no?
Yes, sir. Yes, sir.
So you're damn sure, no doubt about it.
Yes, sir.
Sorry, okay. Proceed.
So shall I continue, sir?
Yes. So you want to ask any question?
Sir,
Dr. Dinakaran, sir. Dinakar Mani. The
Yes, sir.
history, you want to ask any question?
How do you divide the abdominal quadrant, doctor? Makesh. You told left upper abdomen, like hypochondrium.
yes, sir.
So how do you divide the abdominal quadrant? How many quadrants are there?
So total 9 quadrants, sir.
Very good, very good. How do you divide?
Transpyloric plane and tubercular plane. Divides into total 9 quadrants. From mid-clavicular line. So, transpyloric plane from mid-clavicular line and trans-tubercular line divides the abdomen into 9 quadrants.
In a right hypochondrium, which are all the organs located? When you get a pain at right hypochondrium, what are the possibilities?
Sir, right hypochondrium organs, liver, duodenum, gallbladder,
Okay, epigastric area?
sir,
Epigastric area, what are the organs located?
fundus, stomach, fundus of stomach,
Then?
left lobe of liver, spleen, duodenum,
Spleen. Spleen will get in the epigastric area, is it?
no, sir. I'm not just.
Okay, you proceed with your case. Later we'll come back. You proceed with your case.
So, patient had a breathlessness on exertion since 45 days. It was gradual in onset, slowly progressive nature, aggravated on in walking initially during working hours, which was get relieved after getting some rest. Now it has worsened from past 15 days, and while talking, he had breathlessness. He had no history of paroxysmal nocturnal dyspnea, orthopnea, platypnea. Patient belongs to MMRC grade 3, sir, 3 to 3. There is a history of bilateral lower limb swelling since 15 days. Started in both foot at the same time and progressed to legs. It was not associated with the decreased urinary output, facial puffiness, scrotal swelling. No ulcers or discharge from the limbs. Patient had history of fever since 3 months, which was a low grade for 2 to 3 episodes, intermittent nature in last 3 months, associated with chills and rigors with evening rise of temperature, which was relieved on medication. The fever was not associated with yellowish discoloration of eyes, high colored urine, clay colored stools, or any bleeding manifestations. No cough, no cold, no expectoration, no breathlessness, no burning.
Mahesh,
sir,
you told he was breathless, no?
Sir?
Initially, you told breathless. Then how you are telling that no cough, cold, expectation, breathlessness? You told he was breathless, no?
Yes, sir.
Contradicting your own statement.
Sorry, sir. Sorry, sir.
You have to think twice before you leap.
Sorry, sir. No burning micturition, no lower abdominal pain, no joint pains, rashes and bone pain, not associated with any nausea and vomitings. No history of alleged discoloration of eyes, no itching all over the body, no history of bleeding manifestations like hematemesis, melena, hematuria, no puffiness of face, no frothy urine, no palpitations of chest pain, no history of blood transfusions in past, no history of tattooing or high risk behavior, no history of sleep disturbances, loss of consciousness or abnormal movements in hands, and behavioral disturbances. Patient able to pass feces and datus without any difficulty. Past history, there is no history of similar complaints in past. Patient is a known diabetic on tablet metformin since 9 years. Known case of.
So you told the person is an hypertensive with the amlodipine. What we look for in the mouth?
Sir, patient started a recent intake of amlodipine causes pedal edema.
What will you see? Look in the mouth. What will you look for? So you told a lot of things about melena. You told about hematopoiesis. You told about hematuria. So this person is on amlodipine. What will you look for in the mouth?
Bleeding manifestations.
Why? Why you look for bleeding manifestations in the mouth? Any amlodipine will produce oral ulcer, is it? What does it produce? What's the important side effect of amlodipine?
Yes. Amlodipine causes gastritis.
Gastritis. You are giving right and left for all the patients who come to the OP. They produce gingival hyperplasia. Enna? Mahesh.
Sir.
Can you hear me?
Yes, sir.
Can produce gingival hyperplasia. Okay.
Okay, sir.
You mentioned about melena and all that, but you didn't mention a bleeding comes. Was there any bleeding comes?
No, sir. He's not having any bleeding gums, sir.
So on amlodipine, you have to see for gingival hyperplasia. Okay. Yes.
What other causes of gingival hyperplasia, Mahesh?
Sir.
Which other condition will get gingival hyperplasia? Such that amlodipine can cause gingival hyperplasia. What other conditions will get gingival hyperplasia? Gum hypertrophy.
Phenytoin, patient on anti-epileptic drugs like phenytoin causes gum hyperplasia.
Very good, very good. Next. Next. Any?
Sir, patient also in AML also patient will have.
Very good.
Gum hypertrophy.
Oh. Okay, what subtype of AML?
Sir, it is M3, sir.
Very good. Then other causes of gum hypertrophy?
Sir?
Other causes of gingival hyperplasia? You said CCP, calcium channel blocker, amlodipine, and AML. Other causes? Phenytoin, then? Any connective disease or vasculitis?
So Sjogren's syndrome.
No. Any other? Vaginous granuloma. Okay. Any other causes? Okay. Read about it. Yeah, proceed with the case.
And patient is not a known case of congenital heart disease, pulmonary tuberculosis, epilepsy, chronic obstructive pulmonary disease, bronchial asthma.
Keep moving the slide.
Sir?
Oh, sorry. It's there. Proceed.
So no history of blood transfusions, tattooing or high risk behavior. No history of any herbal medication or surgeries done in past. Personal history: he is a 45-year male, married, having 4 children, taking mixed diet. His bowel bladder movements were regular. He is a non-smoker. He consumes alcohol on weekends. He consumes 150 ml of brandy since past 15 years. Family history: no similar complaints in family members. So, a 45-year-old male with abdominal pain, with localized swelling in left hypochondrium, extending into right iliac fossa, which was associated with loss of weight and appetite, with progressive exertional dyspnea of MMRC grade 3 to 4, with no bleeding manifestations, and with the signs of liver cell failure for discussion.
Dr. Mahesh.
Sir.
Dr. Mahesh, you will hear me? Just
Yes, sir.
come back to the previous slide. You said abdominal pain, localized swelling, left hypochondrium, and with signs of liver cell failure. What signs of liver cell failure you came across?
Sir, patient is having pedal edema, sir. Patient is having
Is pedal edema a sign of liver cell failure?
No, sir. No, sir. It's not.
You're saying your patient is having grade 3 to grade 4 dyspnea,
Yes, sir.
and the patient is having pedal edema. So why are you attributing it to liver cell failure?
So no, sir.
So is there any signs of liver cell failure here?
No, sir. Patient is having only pedal edema. In this case, patient is having only pedal edema, but no jaundice, no signs of other signs of liver cell failure, like alopecia, jaundice, parotid swelling, any spider is.
Okay. So I don't think you can put liver cell failure there. Okay. So pedal edema is not a feature of liver cell failure. You're going to go to the physical examination, right?
Yes, sir.
Before? You're going to go. Before that, can you just analyze your symptoms?
Sir,
analyze your symptoms.
So patient had a abdominal pain, which was a dull aching type of pain, and associated with the fullness of abdomen, which started in the left hypochondrium, gradually extended and progressed downwards and medially, with loss of appetite and loss of weight in about 5 kgs in last 3 to 4 months. With the progressive exertional dyspnea, followed by swelling in both lower limbs.
Dr. Mahesh, sir is asking you to discuss. It is not repeating the symptoms.
Yeah.
It's only discussing about the symptom. You're just repeating the symptoms. It is not the meaning of his question.
If you're going to analyze your symptom, you have to say abdominal pain. You have to analyze the abdominal pain, whether this is from visceral organ, luminal organ, from where you think the abdominal pain is. Then next symptom is your abdomen swelling. So you have to analyze that. What swelling are you talking about? So like that, you have to analyze that symptom.
Mahesh, based upon the history, you should come to know whether we are dealing with the pancreatic swelling or any liver swelling or some abdominal organ swelling.
See, I can say this patient is an alcoholic. Yeah, this patient is an alcoholic, abdominal pain. I can tell he has developed a pseudocyst. So you have to discuss your symptoms.
We have not seen the patient, Mahesh. Based upon your brief discussion, we should have a framework of like what organ we are dealing with it, what structure we are dealing with it.
Mahesh, to understand what I'm trying to ask you. So you describe what is the source, what's the cause for pain, what's the cause for swelling.
So due to enlargement of spleen, patient is having pain.
Due to the enlargement of the spleen, he has got a pain over there.
Sir.
So what is the swelling over there?
It's a localized swelling, sir.
Localized, what do you attribute the swelling to? What is the swelling due to?
Swelling might be, swelling is due to splenic enlargement
So you told there is breathlessness. What could be the cause for breathlessness there?
Sir, due to splenomegaly, enlarged splenomegaly, in anemia, and also patient will develop pedal edema, breathlessness.
You told tiredness and all that probably should be, the breathlessness could be because of anemia.
Sir.
Yes or no?
Sir.
We don't know, still we have to examine the patient, but from the history probably should be, it is not cardiac cause for dyspnea, it is not a respiratory cause for dyspnea, it is something to do with anemia. Okay, and as you were describing, you told the petal edema was due to liver cell failure. The petal edema was not a liver cell failure, it could be because of anemia. What was hemoglobin for him?
Sir, hemoglobin is a 6.2. Sir.
Probably the petal edema. So, sir wanted that only. You have to analyze what's the cause for pain, what's the cause for swelling, what's the cause for breathlessness, and what's the cause of petal edema. So you were just highlighting all the 4 points with lot of negative symptoms. So just you should highlight what are all the possible explanation you would like to give for the positive symptoms you have analyzed. Okay, there are plenty of negative, but give a possible explanation for the positives. Okay, yes.
Just one more point, Mahesh. You said loss of appetite because you're saying this is spleen. Will you say the patient had a decreased appetite or he had early satiety? When you're dealing with spleen, you have to say most of the time the patient will have early satiety.
Early satiety.
Okay.
Early satiety.
Rather than saying that the patient had loss of appetite. He could have had loss of appetite also, but one of the feature of splenomegaly is early feature of splenomegaly is early satiety. Okay. And Mahesh, before you go to examination, whenever you're presenting a case, you summarize the history, you have a provisional diagnosis. And you have to have 1, 2, 3 provisional diagnoses. And for each provisional diagnosis, you have to have for and against points for that. Only then you proceed to the examination where you confirm your history. You're not going to make a diagnosis from your examination. All you're going to do is just confirm what you have already gained from your history. Do you have any provisional diagnosis, Mahesh, before you going to examination?
The case of
differential diagnosis 2, 3.
It could be a splenomegaly. Case of splenomegaly.
Splenomegaly is not a clinical diagnosis. You're finding.
Magesh, completely biased by your prefixed ideas of splenomegaly. That's the reason you are not able to answer any of the questions raised by your gastroenterologist or non-amateur himself. Don't think in this manner. You don't get any, the thoughts cannot be like expanded to have a more differential diagnosis, even for the symptom analysis, even for the differential diagnosis for the system involvement, even for the complete diagnosis. So don't get prefixed with an idea, because when you started presenting your case, you said, I'm going to present a case of abdomen, massive splenomegaly for examination. So probably your ideas are completely fixed. Understand, Magesh?
Okay, sir.
So that's the reason whenever Harivarsan sir or Dinagaramani is raising some points, you're not able to think beyond that. Just able to understand, you're thinking what else to be discussed. It's only splenomegaly cause. What else they're asking me? That's how I think your thought process is going. Never get fixed. You may be very, very perfect in your diagnosis, but it is not the diagnosis you are arriving at. It is how you're going to arrive at the diagnosis, how you're analyzing your symptoms, how you're analyzing your signs and correlating both these things and coming out to a conclusion. Understand? So don't get panicky. What they're trying to make it very easy for you to is just to make you to think how you should be thinking in the exam point of view. Okay? I think you're finding very difficult to find out the answers or tell the answers. Don't get panicky. Please feel free and don't prefix your ideas. I think you're a bit of fixed with your ideas of your diagnosis starting from the beginning. And when you present your symptoms, at the end of the symptoms, you are saying signs of liver cell failure. The symptoms, when you are analyzing, it cannot come out with the signs.
Okay, sir.
Understand? It's all simple points, but it does carry a lot of meaning in your understanding of basics. Understand? So it does carry a lot of meaning on the understanding of yours of basics. So probably you can just keep your eyes and thoughts a bit open and try to understand the question. Don't think of it only spleenomegally. Think broadly and try to answer the questions. Understand? Please, other faculties.
Sir, sir, differential diagnosis will be ascites, ascites with spontaneous bacterial peritonitis. Portal is cirrhosis with portal hypertension.
So is there any history suggestive of cirrhosis in your patient, Magesh?
No, sir.
So you're coming out with some diagnosis only based on your symptoms of the patient, analysis of the symptoms, right?
Okay,
So this patient has got some constitutional symptoms, right? You said fever, history, loss of weight, and fatigability. All those symptoms are there, along with probably it's a focal enlargement of some sort of part of the abdomen and progressing in a classical distension or classical movement of the abdomen distension, along with constitutional symptoms. You said, right?
yes, sir.
Correct? So keeping it that mind, what are the possibilities? Don't think you are dealing with only spleen. Don't think you are dealing with only spleen. Forget about that. Try to think bit open and try to come out with some differential diagnosis.
So infectious causes like malaria, infectious causes malaria, and any infiltrative causes like sarcoidosis, malignancies.
They want just a differential diagnosis. That's all. So the first possibility we told it is decompensated liver disease. Second, you said malaria. Okay. Then third, what is running through your mind?
Alcoholic abdominal pain, particularly upper abdomen, some swelling of the leg.
Alcoholic liver disease, alcoholic hepatitis.
Can it be? Yeah. Okay. Then, but should be a right upper abdomen, right? Yes, some left upper abdomen pain.
Left abdominal pain.
Usually, all hepatitis will be associated with some jaundice will be there. Right upper abdomen pain, fever. He has predominantly left upper abdomen. So abdominal pain, left upper abdomen, fever, swelling of the legs. What would be the other possibilities? What is your first differential diagnosis?
Pancreatitis, acute pancreatitis.
How many months? Your symptoms, how many months duration?
Duration of 3 months, sir. Started 3 months back.
So they cannot be acute, right? 3 months.
Sir.
Magesh, what is your first differential diagnosis?
Sir,
You put together all. Someone is having a middle age, the abdominal pain, fever, swelling of the bilateral lower limb, alcoholic. What is the first differential diagnosis?
alcoholic liver disease.
Okay, then second.
Anemia can also. Malaria, anemia.
Okay, so we want to put some malaria. Okay, second, third.
Any malignant cause?
Gastrointestinal GA malignancies.
What GA malignancy?
Gastrointestinal tumor. Gist, sir.
Okay, then could be some lymphoma.
Yes, sir. Lymphoma.
Okay, what else? Can be a tuberculosis.
It's a disseminated abdominal tuberculosis.
What else? Can be some chronic pancreatitis and E. coli.
Chronic pancreatitis. acute polycystic.
Now what you have to do is, based upon these many differential diagnoses, what is the pros and cons for each individual differential diagnosis? Arivasan, you want to add something?
No, just let him come up with the for and against points for
each individual diagnosis. For example, you said first diagnosis is chronic liver disease. What is the pros and cons for chronic liver disease?
Patient is alcoholic.
Okay.
Patient is having breathlessness, pedal edema.
Okay. In a patient with alcoholic liver disease, we get abdominal distension first or swelling of the leg first? Which one we'll get first?
Then abdominal distension.
Why?
Abdominal distension due to ascites. Will be abdominal distension.
Okay, there should be some diffused abdominal distension, right? You are trying to tell there is upper abdomen, not a diffused abdominal distension. Okay, can it be alcoholic liver disease? Okay, what are the points against alcoholic liver disease? No jaundice.
No jaundice.
No other signs of liver cell failure.
No signs of other signs of liver.
Okay, so one diagnosis will keep it as a chronic liver disease. What is the second diagnosis? Second diagnosis. Infectivity, you want to put it together, some tuberculosis or malaria.
Abdominal tuberculosis.
Okay, what are the pros and cons for our tuberculosis?
Loss of weight, loss of appetite. Patient is having loss of weight, loss of appetite associated with abdominal pain, with breathlessness. Pulmonary, maybe involving pulmonary.
Okay. So
Mahesh, can this patient have abdominal tuberculosis and have a lump abdomen there in the left quadrant? Is it possible?
Yes, sir. Due to
How? What types of abdominal tuberculosis are there? So sometimes abdominal tuberculosis patients develop a cocoon abdomen. So the intestines and the parts of the mesentery are all clumped together. That can also present as an lump abdomen. If patient can still have pain, you can explain loss of appetite, loss of weight, fever. It can be explained. You keep it in your differential diagnosis. See, this might not be the final diagnosis, but once you keep differential diagnosis like this, then the examiner will know that you're thinking. So you're not prefixed to a particular. See, you know the diagnosis already. Which case you're presenting, probably you know the diagnosis. You can't show directly to the examiner also. So you have to make differential diagnosis. Like Dr. Dinagar said, you can, in an alcoholic patient with an abdominal pain, then he develops swelling. It can be a chronic pancreatitis which has developed into a pseudocyst has enlarged. So if you stick to only splenomegaly, you are going to keep only one differential diagnosis and you are going to keep only one final diagnosis. That should not be your approach. What everyone is looking for is how you approach this case. In a patient, 45-year-old, alcoholic, abdominal pain, swelling, he's having these constitutional symptoms. Okay, so that is a point we want to get across to you, that you can make many differential diagnoses. At the end of your examination, whichever has the most 4 points, that will come to the top. Okay, so this is how you arrange your differential diagnosis. Whichever differential diagnosis has the maximum points will come up. Whichever has the least number of points for it will come down. Okay.
Any other differential, Mahesh? 4th, 5th, 6th, you want to add?
Sir?
Bring more differential. It will be easy for us to discuss, no?
Yes.
Which malignancy you want to link? Which malignancy? You want to bring some lymphoma?
Lymphoma, yes, sir. Lymphoma.
What are the pros and cons? Okay, what is the other differential diagnosis? Any other than lymphoma? Anything associated with some retroviral diseases? fever, leg swelling, abdominal pain, could be a retroviral diseases.
Aries leukemia.
HIV. Okay. What other differential diagnosis? Can you just summarize like how many differential we told? First is the chronic liver disease. Second,
Chronic liver disease, TB abdomen, chronic pancreatitis, lymphoma,
chronic pancreatitis, lymphoma,
chronic pancreatitis, Aries leukemia, pseudocyst, pancreatic pseudocyst.
No, that's you said no. Chronic pancreatitis and sequelae. Then what else? Final can be.
Mahesh, one point. Mahesh, just one point.
Yes, sir.
Never make pathological diagnosis in your exam. Harrison leukemia, do not make a diagnosis of Harrison leukemia. Okay. If in case the patient really has Harrison leukemia, you might be failed. Okay. They will know that you know the case. So never make pathological diagnosis. You can make probably this is a case of massive splenomegaly, most likely a infiltrative disorder, which I believe could be a leukemia or a lymphoma, like that you can say, or some malignant. Don't make pathological diagnosis. That will go against you.
Oops. Thanks.
The other way is, Magesh, to approach this patient, probably you can say like the patient is having a lot of constitutional symptoms. You can think about, am I dealing with immunological disorder, infiltrative or infective? You start thinking about that way. And moving on from that point, what are the possibilities to have a left side swelling of the abdomen? Probably it's a better way in an exam point of view, instead of thinking about or telling or enumerating the causes of the differential diagnosis, as Dr. Arivarsan was mentioning about the pathological diagnosis, better to be avoided. Don't commit yourself, you'll be trapped and you'll be in trouble. So instead of say, you can say, sir, because of these 3 months, nearly 12 weeks, this is a huge period of constitutional symptoms. You can think about chronic infections, inflammatory conditions, chronic inflammatory conditions, and followed by malignancy, definitely. And probably you can think about, because if you feel like at the end of your history, you feel like you're definitely dealing with one of the differential diagnosis for the organ involvement. If you feel like spleen, you can also think about, is it an effect of some other systemic disease producing splenomegaly, or is it a primary disease of the splenic enlargement which produces systemic symptoms? So there are so many ways to approach. What I'm trying to tell you, or everybody is trying to tell you, is just how to approach a clinical problem. Understand, Magesh?
Okay, sir.
Yeah, try to understand that. Yeah.
Thank you, sir.
I think we'll move on to the examination case.
Okay, sir. Sir, general examination. Patient was examined in a sitting position. Patient conscious, thin built, oriented, and febrile. Height is 156 centimeters. Weight to 42 kgs. BMI. So sorry, sir. BMI was not calculated. BP was
Okay,
110. Sir.
Oh, proceed.
BP was 110/70 in millimeter of mercury in right upper limb. Pulse rate 102 per minute. Regular rhythm, normal volume, and the condition of vessel was normal. Saturation was 97% in room air. His respiratory cycle is 20 cycles per minute. This is a picture. This is a patient clinical picture taken with permission. So general examination, patient had a pallor, bilateral pitting, pedal edema present in lower limbs, or medial malleolus of both lower limbs with a slow pace of recovery. Clubbing in both upper limbs with bulbous enlargement of distal phalanges of grade 1. Patient had a trivial sternal tenderness. There is a localized abdominal swelling in the left program. And patient had a submental lymph node enlarged, which was 1 into 1 centimeters. Consistently not matted. Skin over the node is normal. And he had bilateral inguinal lymph nodes enlarged 1/2 centimeters. non-tender, firm in consistency, not matted. Skin over the enlargement node is normal. And left supraclavicular lymph node was not palpable. JVP is normal. This is the picture of a pitting pedal edema or a medial malleolus with a slow phase of recovery. Clubbing with the distal bulbar enlargement of grade 1. This is a picture showing asymmetrical swelling in the left hypochondrium. We had no signs of right heart failure, no signs of no external markers of tuberculosis, and no external markers of HIV. Coming to
Positive
1 second,
finding in
Mahesh,
general
Mahesh,
examination. Positive find general examination is pallor.
Sir,
Pallor. Then we had inguinal lymph node.
patient is having pallor, bilateral inguinal lymph node, submental lymph nodes enlarged.
Then we had got clubbing and pedal edema.
Yes, sir.
Then what are the causes for inguinal lymph node enlargement? Told 2 centimeter, 1.2 centimeter, probably significant also. What was the cause for bilateral inguinal lymph node?
So, bubo, lymphogranuloma venerum.
Lymphogranuloma venereum, chancroid, syphilis, and herpes infection. So that can produce bilateral. So lymphogranuloma venereum, chancroid, syphilis, and it can be herpes simplex virus infection genitals. So that can produce bilateral inguinal lymph node. Has it got any relevance to this case? Bilateral inguinal lymph node enlargement? Or just incidental finding?
So the incidental findings, sir.
Has not got any relevance to this case. Yeah.
Yes, sir.
Yes.
And Mahesh, 1 second.
Yes, sir. Yes, sir.
Let's come to your examination. In your diagnosis, you had kept up signs of liver cell failure. There you had kept it after history. You have not looked for any signs of liver cell failure here. Your first differential diagnosis is a decompensated liver disease. Okay. You have not looked for liver cell failure here. The next thing is clubbing. With your first differential diagnosis of DCLD, can you explain clubbing in this patient? What could cause clubbing in a patient with decompensated liver disease? In a patient with liver disease, cirrhosis, what can cause clubbing?
Hepatopulmonary syndrome.
Yeah, exactly. Hepatopulmonary syndrome. Patient developing hepatocellular carcinoma, he can develop clubbing. Okay. Then inguinal lymph nodes in a patient with pedal edema, gross pedal edema. These patients are also more prone to develop cellulitis, and these patients also can have inguinal lymph node. Okay, usually unilateral will be unilateral, but yeah, sometimes even bilateral can occur. Okay. So you have not looked at liver cell failure. In this case, you should have looked at liver cell failure.
The patient is not no signs of no jaundice, no alopecia, no parotid enlargement, no spider neck. Patient is having no distended veins over the abdomen. There is no scrotal swelling, no testicular atrophy.
So add it in your this examination. Tell the examiner, show the examiner that you have seen it also.
Okay, sir.
Okay. Yeah.
So coming to systemic examination, inspection, examination of oral cavity in a sitting position. The patient had no bleeding gums or hypertrophy seen, no fetal hepaticus, no dental caries, no engorged veins below the tongue. Tongue is pale, no oral thrush. There is staining of betel nuts present, sir. Lips are normal. Inspection.
You told the patient was anemic. Yeah. What are the other things you see in the oral cavity? You told the patient was anemic, no?
Yes, sir.
General examination. What will be the other findings that will give credential to you when you examine the oral care? That will give credential to you when you present.
Ulcers.
Ulcer.
Hypertrophy. Gum hypertrophy.
So you have told there is no hypertrophy. What else? Can you see for glossitis, angiostomatitis?
Gum bleeding, glossitis.
Angiostomatitis. அதெல்லாம் சொல்லணும்ல beetle and stain எல்லாம் சொல்லியிருக்கேன், but இது you have to tell, no? Since you told anemia, you have to see for all that. Yes or no?
Yes, sir. So inspection, patient in supine position with the hand side of the body and knee flexed in position. Shape of abdomen is asymmetrical. Skin over the abdomen is normal. There's a localized swelling over abdomen on left side, directed diagonally towards umbilicus and right iliac fossa. The swelling was moving with the respiration in both, moving with the both phases of respiration and respiration. All umbilicus is retracted and inverted. Inguinal orifices, there is no swelling, there is no scrotal swelling, no engorged veins, pubic hair present, no scars, no sinuses, no discoloration of skin or pulpal striae.
What about palpation? Mahesh,
Sir,
after inspection, go for palpation.
Yes, sir. So coming to palpation, superficial palpation, there is no warmth and no tenderness. Deep palpation, mass palpable in left hypochondrium. Extending towards right iliac.
Told there was a pain, abdominal pain, no?
Yes, sir.
You told in a history that the person has got abdominal pain, but on palpation, superficial palpation, he was saying that there is no tenderness. Did he have tenderness or not?
Sir, he's not having any tenderness. The patient is not having any tenderness, sir.
Is it so? When we test the spleen, did he have pain the other day? Sure.
Yes, sir. He's having pain, sir. On the deep palpation.
No tenderness. So I too touched his abdomen. When we were touching the spleen, was wincing with pain.
Yes, sir.
Is it not so? He had
pain only on the deep palpating. While palpating, he's having a tenderness and deep palpation.
So in deep palpation also, I don't think you have given any idea of how tenderness here. So proceed, doesn't matter. So you have to be very confident of your findings. Okay. After that will be cakewalk for you in the exam. Otherwise, you have to face a difficult situation, both yourself and the examiner. Yes. So whatever you say and get away. That's all.
Mahesh, you said some abdominal sinuses and all.
Sir?
You look for some abdominal sinuses. Which are all the conditions you get abdominal sinuses? What is sinuses? Why do you look for sinuses?
I can't understand.
No, in inspection, last line you mentioned about no scars, sinuses and all.
Yes, sir.
The previous line of inspection.
Inspection, the last line, no scar, no sinuses and all. Which condition can be associated with some sinuses? Abdominal pain, fever, weight loss, leg swelling. Okay, we will discuss later. Okay, first proceed.
TB in TB patient.
Yeah, exactly. Exactly. Then any other diagnosis? Any other differential?
Starts with A.
Okay, proceed, Mankesh. I heard about IBD, Crohn's disease. Okay, you proceed.
Aesthetic tapping puncture will have any scars and so on.
No. We proceed.
Palpation, deep palpation, a mass palpable in left hypochondrium extending towards right iliac fossa. Mass in firming consistently, non-tender, moving with respiration, not able to get above the swelling. Borders are regular and notch filled. Measurements: abdominal girth to umbilicus at 80 centimeters, xiphisternum to umbilicus 18 centimeters, umbilicus to pubic symphysis is 14 centimeters. Spino-umbilical measurement was decreased in right side by 2 centimeters when compared to left spino-umbilical measurement. And the testis was normal in size, sensation was present. Palpation. So I can palpate the spleen post the umbilicus, till the post umbilicus. Percussion, liver borders were upper border in 5th and 6th intercostal places. Lower border is swelled in 2 centimeters below the right costal margin. The liver span is of 15 centimeters. Nixon's method, spleen is using Nixon's method. Spleen enlargement was more than 8 centimeters from lowest lung resonance and posterior axillary lines, perpendicular to mid left costal margin. It is more than 8 centimeters. Castel's point, there is a positive Castel signs in a 9th intercostal space in an anterior axillary line. Top space was obliterated. The dullness noted from left hypochondrium up to 2 to 3 centimeters below umbilicus towards right iliac fossa. No shifting dullness and no fluid thrill present, sir.
Mahesh, 1 second. Just go to the spleen examination. Obviously, it is a massive spleen. So you're given these three methods: Nixon's, Castel's, and obliteration of drop space. Okay. This case, forget this case. This is a large spleen. Okay. These methods are in cases where the spleen is not actually palpable, but you need to find out whether there is a splenomegaly happening. Okay. Among these three methods, which is a most sensitive method to detect splenomegaly? Most sensitive.
Nixon's method.
It's Castel's method. Castel's.
Oops.
This is even before you feel the spleen palpable. These techniques are basically to identify splenomegaly early. Okay, so when you're just percussive, if you're not able to feel the spleen in the abdominal cavity, if you do a percussion in the anterior axillary line and it is dull, it is more sensitive that the patient is having splenomegaly. Okay.
Oops.
And you have proceeded to the other system examination.
Yes, sir.
After this abdominal, you have not gone to the auscultation. Is auscultation important in this case?
Sir, auscultation, bowel sounds, gurgling sounds heard in all 4 quadrants. There is no bruit, no venous
Okay.
sound, no succussion splash, no friction rip.
Okay, 1 second. In this this is a spleen, right? This is a massive spleen. Will you auscultate over the spleen or not? What will you look for?
Splenic rub.
Yeah. Why splenic rub? I'll tell you. If you come to your history, you are saying abdominal pain. The patient is having abdominal pain. It's a dull aching pain. It is intermittent pain. Why do you say intermittent pain in a patient with splenomegaly? Why will a patient who is having an enlarging spleen have intermittent pain? He will have a dull, dragging type of pain. Okay. So, what will cause intermittent pain, sudden intermittent pain in a patient with massive splenomegaly? You told it already. What will cause pain in a spleen?
Stretching of capsule causes.
That will cause a constant dull aching pain. That will not cause an intermittent pain. So, what will cause an intermittent pain in a patient with massive splenomegaly?
Splenic infarctus.
Yes. So splenic infarct. Splenic infarct will produce your splenic. It will produce a splenic rub. Okay. That is why hospital in such a massive spleen where you're giving history of patient having intermittent pain, you should always look for a splenic rub. Okay. Okay. Proceed.
So auscultation and
Yeah, Mahesh, wait. You told, you have confirmed it. It is clean. There's certain other things we have to talk about: the surface, the consistency, what margins you have made, whether you have seen for the splenic notch,
Yes,
and
yes,
what are the
yes.
other maneuvers you do, whether you're able to insinuate the finger, whether it was ballotable, whether it was bimanually palpable. All this should be done to differentiate it from the renal mass.
Okay, sir.
You didn't mention all that. Why? It's going to be a long case. You have to mention all that. You have to differentiate between the left kidney and the spleen. Have you forgotten?
Yes,
That is basic medicine, no?
yes, sir.
You have mentioned about Nixon method, Castile method, and all that, but you haven't you didn't give any description about the spleen on palpation. Why?
So to compare from renal enlargement.
Nilla, why you have forgotten?
No, no, sir.
Tell me. You have to confirm it as a spleen, no? Hmm? Yes or no?
Yes, sir. Yes, sir.
So we believe more on ultrasound and CT scan rather than clinical examination, probably. Illa Mahesh? Exam la vandhu no ultrasound, no CT scan, no MRI. It's only clinical examination. So what was the spleen like? We examined, no, both of us.
Yes, sir.
So you tell about the spleen now.
Yes. Spleen was not palatable, sir. Not palatable.
Illa, first, how many centimeters below? What was the surface? What borders you have made out? Whether you were able to make the splenic notch. All this we have to mention. Then you talk about palatability, bimanually palpable, and insinuate the finger. All this.
Okay, sir.
Mahesh, go in order. Tell.
Sir.
The other day you have seen it, no? That was a big thing.
Sir, shall I continue, sir?
So go for others. Says don't make mistakes like this.
Okay, sir.
His undergraduate doesn't matter. For undergraduate also we have failed so many students who have put AS instead of MS. But for a postgraduate, if you present like this, definitely you have to face the consequences. Okay.
Okay, sir.
Yes.
Other systems, cardiovascular system, S1, S2 head in all areas. Respiratory system, bilateral area interpresent, normal respiratory presence all over lung fields. Central nervous system, patient is conscious. There's no astraxis, no focal neurological deficits. It's a case of massive splenomegaly for discussion. My differential diagnosis were lymphomas, leukemias, tropical splenomegaly syndrome, metabolic disorders like Gaucher's disease, infectious causes like chronic malaria, Kala Azar, hematological disorders like autoimmune hemolytic anemia.
Yes, you cannot put so much diagnosis. It can be only, you should be very dogmatic. There can be only one or two diagnoses, not like this. So pertaining to all your history, your general examination finding and physical finding, ultimately you have to boil down to one or two differential diagnoses only. For discussion's sake, we can say, but when you come for the end of your presentation, at least there should be only one or two. In olden days, there'll be only one diagnosis. It will be the final diagnosis, even without the advent of all the CT, MRI, and all the other investigating modalities. Our teachers, they'll come for a final diagnosis, and invariably, most of them will be correct. We used to admire them for the presentation in MMC and KMC. Huh? When we go for rounds along with them. So there should be only 2. So what is you pick and choose which should be the best among all these 5 or 6 differential diagnoses you gave?
Maybe lymphomas, leukemia, and lymphomas and leukemia, sir.
Huh?
Lymphoma,
leukemia, and
hematological disorder like autoimmune hemolytic.
you haven't told autoimmune hemolytic anemia. He never had any jaundice, anything like that.
Sir, no, sir. He's not having any jaundice. Sir, chronic malaria can also.
So you are sticking on to only 3: lymphoma, leukemia, and what's that? Tropical splenomegaly syndrome. The top 3 will get the priority. Appadane? Seri. So discuss, sir. You would like to ask any questions, sir?
What is in favor of
Magesh?
Sir.
Dinagar, please. Dr. Dinagar, please.
Based upon the clinical finding, the last one.
Sir.
Audible? Mahesh, can you hear what sir is asking you?
No, sir, not audible, sir.
Dr. Dinagar has put himself on mute, I think.
Magesh, only one question from my side.
Yes, sir.
Based upon the clinical examination, if you want to differentiate whether we're dealing with the spleen or kidney or maybe some transverse colon mass or maybe a gastric mass, with the fingers, how do you differentiate these 3 things? What do you want to put a finger into which place? Spleen, kidney, maybe a gastric mass, just or maybe a transverse mass. To differentiate these 4 things, the solid finding for a spleen, what will be the clinical finding? With your fingers, you have to touch it inside some place.
Insulation of a finger, sir.
Have you discussed about that one?
No, sir.
When you describe about the spleen, conclusion, if you want to give a diagnosis of spleen, you should give some solid points. This Nixon, gas, space arbitration, and all more of subjective variation.
Okay, sir.
Lot of subjective variations. So you should have some solid points. As Sat said, you should discuss about, you should have discussed about bimanual palatability and finger insinuation. These are all things very important. Okay. So now we'll come to the differential diagnosis. Sorry, you want to make something?
Yeah, Mahesh.
Sir.
Hello. Yeah, Mahesh. You kept differential diagnosis of lymphoma, leukemia.
Sir.
What are the points in favor of this? For argument's sake, I am telling this is a case of non-cirrhotic portal fibrosis or extrahepatic portal vein obstruction, where again you can have massive splenomegaly. You oppose me. You tell me what is wrong. I am telling this is a case of either EHPVO, extrahepatic portal vein obstruction, or a non-cirrhotic portal fibrosis. In both these cases, you'll have massive splenomegaly. You tell me the points. What is there in favor of lymphoma or leukemia? No.
Constitutional symptoms, weight loss. You add up.
Constitutional symptoms, weight loss, loss of appetite.
Yeah.
Massive splenomegaly.
So you are having points, right?
With bilateral lymph node enlargement. All this comes to put this diagnosis.
So tell it boldly that you have these many points. Okay. So I'm telling you some diagnosis. Say there are points against it. So look at the rapidity with which the spleen has enlarged. Patient has developed abdominal pain within 3 months. In 2 months, the abdominal swelling has increased.
I see.
And that abdominal swelling you have examined and found it to be a spleen. So in which conditions can the spleen rapidly enlarge to that extent. If you are talking about non-cirrhotic port fibrosis or extrahepatic port fibrosis, these are all chronic causes, long-standing disorder.
Long-standing.
For even Gaucher's disease, you have kept Gaucher's disease. These are all long-standing conditions. So anything that is going on in 2 months is something really going rapidly. So rather than saying lymphoma or leukemia, say it could be some infiltrative pathology that you're thinking about. Okay.
Okay, sir.
Yeah. See, lymphoma is infiltrative pathology. Leukemia can also be there. Amyloidosis can cause some rapidly progressing infiltrate. Some rapid sarcoidosis. Some infiltrative pathology is going on that is going rapidly. So that is why with constitutional symptoms of fever and these things, loss of appetite and loss of weight, I would like to keep a something like a lymphoma or a leukemia here. That is how you will go. Okay. It can still be TB.
Yes.
Okay. So make points for yourself. Make more points. Whichever you're keeping as a first diagnosis, you can't just say, I made a diagnosis of massive splenomegaly, first diagnosis lymphoma. Stand for that. What? So instead of putting as lymphoma, leukemia, say some infiltrative disorder. And in infiltrative disorders, look at which can be the higher possibility. Like that, you keep it. Okay.
Okay.
Don't keep us a Gaucher's disease on the diagnosis. Have a discussion.
Sir.
Don't have a diagnosis of Gaucher's.
Sir. Metabolic disorder. Gaucher's disease.
In infiltrated disorder, why do we get a splenomegaly? Why do we get an enlargement of spleen?
Sir, the infiltration of liposomes in the macrophages. Sir.
What is the role of spleen, Magesh?
Sir?
What is the role of the spleen?
Reticuloendothelial epithelial organ, secondary lymphoid organ.
Please, what are the functions of the spleen?
What is the function of the spleen? What is the role of the spleen?
Sorry.
Why do we need a spleen?
So for opsonization, for RBC destruction, producing antibodies.
Which antibody?
Sir. Opsonization for destruction of RBC cells, old RBC cells.
Removal of the RBC. Okay, then what else? Whenever there is a more destruction of the RBC, more the work turnover, that is the reason we will get splenomegaly in a hemolytic anemia. Then infection in a malaria or cholera, why do we get a splenomegaly?
Sir,
in infective conditions, why do we get a splenomegaly?
Parasite infiltration in macrophages, which also malaria also there will be sequestration of RBCs.
In general, the spleen has one important role is removal of dead RBCs. Second is clearing of all the toxins. That is the reason we'll get a splenic hyperplasia in all infective etiology. And a major role is production of IgG, immunoglobulin. So that is the reason we will get splenic enlargement, immune overreactivation in all infiltrated disorders. Okay, proceed, Magesh.
So if you look at any splenomegaly, Mahesh, just if you take any cause of massive splenomegaly or any cause of splenomegaly, rather than saying disease-wise, you can say pathology-wise, where there is a increased work of reticuloendothelial system, like Dr. Dinagar said, in AHA or tropical splenomegaly. Then due to passive congestion, that is due to portal hypertension, congestive heart failure. Then the third one is your infiltrative. If you classify it into 3, then you can see, you can just put your differential diagnosis into those things. Okay.
Okay, sir.
Okay.
What is the normal size of spleen, Magesh? Normal weight.
Normal 200 grams, 150 to 200 grams.
When do you say it is a splenomegaly?
So it is if drive weight is more than 1,000 grams.
More than the, what is the blood flow to the spleen? What is the amount of blood flow to the spleen
Sir,
per minute? What's the blood flow to the spleen?
70 ml. 70 ml.
70, 150 ml. 150 ml per minute. Hmm? Yes. Proceed. Go for the investigations now.
So investigations are done. Complete weight picture shows RBC with 2.3 million. Hemoglobin was 6.2 gram per deciliter. Platelets with platelets 1.2 lakhs. MCV was 65. Total count was 84,000. Sir. And his viral markers was done. Shows HCV is negative, HBS AJ negative, and VCTC is negative. Serum LDH was elevated, ESR was elevated. LFT was a liver function test done. SGOT show is 34, SGPT 42. Total bilirubin was 2.2 mg per deciliter. Alkaline phosphate was ALP was 147. So RFT was done within normal limits. Serum electrolytes within normal limits. Then peripheral smear was done, sir. Peripheral smear shows severe microcytic hypochromic RBCs with polychromatophilics RBC seen. WBC count increased with the presence of myeloblast 2%, promyelocytes, band forms, and neutrophils. Platelets are just adequate with the giant forms. No hemoparasites seen. ECG was done. ECG shows normal standardization with the normal sinus rhythm. Heart rate showing heart rate with 80 beats per minute. RRA interval regular. There is a left ventricular hypertrophy present. 2D echo was done in this patient. Shows moderate TR with minimal pericardial effusion with mild LVSD and ejection fraction is 48%. Sir,
Have you done a bone marrow biopsy for him? No.
Sir, actually, patient planned for a bone marrow biopsy, sir. We have tapped for 2 times, sir, but it is a dry tap, sir.
Yes, what is the retic count? You haven't mentioned about retic count. Reticulocyte count. What is this retic count? What is the importance of retic count?
So the reticulocyte count will be increased, sir.
Increased. You are trying some dry tap and all. Dry tap, you are increased.
Sir, reticulocyte
So
count sir, in hemolytic anemia, we can include for a hemolytic anemia.
When you're trying to develop pancytopenia, the most important thing is retic count.
Yes, sir.
Be increased or decreased, man?
Sir?
To be increased or decreased?
Sir, actually,
effective erythropoiesis. What will happen to
reticulocyte count was not mentioned, sir, in this.
Huh?
So the reticulocyte count was not mentioned.
What mentioned?
Not mentioned where?
Sir, in
Siri, it is not mentioned, but what do you think?
Report has not, sir?
Lilla, what do you think? It's not mentioned. That doesn't matter, but what do you think? Whether it's reduced or increased?
Asking what is the importance of reticulocyte count in this case? What is the importance, man? What is the importance of reticulocyte count?
Aplastic anemia, hemolytic anemia. It will be decreased, sir.
Where?
In this, in my case, it will be decreased, sir.
Louder.
What will be the
in my case, I expect there will be a decreased reticulocyte count.
Siri, they have told severe microcytic hypochromic RBCs. What is anisocytosis? What is poikilocytosis? Change in size is anisocytosis, poikilocytosis, change in shape. So what are Hen's bodies?
Means what is?
Huh? What are Hen's bodies? Denatured hemoglobin, the RBC. What is Hubble-Jolly bodies?
Sir, nucleated RBCs.
Nuclear remnants in the RBC, not nucleated RBC, nuclear remnants in the RBC. So they have told the WBC count is increased. What are the other cells you like to see? Myeloblast, promyelocyte, myelocyte band forms a neutrophil. So whether he's in blast crisis or what?
Sir, no, sir.
When do you say it is blast crisis?
Increased blast cells more than 10 to 90%, 19%.
90.
19. More than 10 to 19% of basophils, blast cells with the increased basophilia count.
When do you say the person is in blast crisis? What should be the blast count? How many percent?
So 10 to more than 20%, sir.
Is he in blast crisis or not? That's what I want.
More than 20% blasts.
Huh?
More than 20% of blast cells. Is seen in blast cases.
More than 5% blast cells, if it is there, is going in for blast crisis, then there'll be thrombocytopenia, but he has only adequate platelet. Apart from that, there'll be increase in basophils. That is also not there here. So it's not in blast crisis. Where is the other one? Peripheral smear picture.
Yes,
What will happen to the platelet count?
So platelet count will be there will be a thrombocytosis or there will be a thrombocytosis.
What will you are like CML? That's what you said. So what will happen to the platelet count here?
Platelet will be decreased, sir.
Decreased.
Yes, sir.
Or there will be thrombocytosis. So whenever there's a peripheral smear, we have to analyze all this and see where you stand. So platelet is just adequate with few giant forms.
Okay.
Arrow is not done. Then go for the next investigation.
মারা গেল করে ফেললো 4 দিনে পরে শুদ্ধ হয়ে গেল খ্যাতি পুষ্টিরা হয়ে গেল খ্যাতি পুষ্টিরাও করলো সব হ্যাঁ হ্যাঁ করতে পারে তো এটা অল্প দিন বড় খ্যাতি পুষ্টিরা করলো আবার আমাদের
can I make one comment over here?
হয়েছিল সে মেয়ের বাড়ি ক্যান্সার হয়েছিল সে মেয়ের বাড়িতে গিয়ে যে মারা গেল তারও 4 দিনের পরে
Sir, can I audible, sir? Am I audible, sir?
Yes.
Yeah.
So shall I continue, sir?
Yes. There is a disturbance.
So it's in my case is a case of CML.
At last you came to a definite diagnosis, sir.
Sir?
At last you came to a definite diagnosis.
Sir.
Okay.
So we patient plan for flow cytometry and fish study, sir. I have done bone marrow aspiration, but it is only dry tap, sir.
Yes. Straight into a bone marrow is a dry tap. Okay. So what is the hallmark for chronic myeloid leukemia? If you do the flow cytometry and the fish studies,
Yes, sir.
What will be the hallmark?
Sir, translocation of BCR ABL gene. We have to look for
Translocation which arm? Which arm and which chromosome?
Chromosome 9 and 22, sir. There is a translocation of BCRL and ABL genes. This,
Long arm or short arm?
Short term, sir. And
Short arm. படிக்குமோ நல்லா படிக்கணும் தம்பி.
sir. Short term, sir. It is a this translocation leads to tyrosine kinase activity, which is increases tyrosine kinase activity.
So what are the other systemic manifestations that you can expect in a patient with CML?
So bleeding manifestations can be seen, sir. In late presentation.
Then any cardiovascular, any respiratory, any thrombotic manifestations?
No.
That's what we expect you to find out in cardiovascular system examination, respiratory system examination, and the local examination of hand or foot. What are the other systemic complications you expect in a patient with CML?
In a male patient, CML, what else history can you ask? Like sir asked for thrombotic.
You get it rabies also. What is it?
So I didn't get the question, sir.
You didn't get a?
So I didn't get the question, sir. I didn't understand, sir, question.
See, CML, it is a multi-system disease. It can involve the cardiovascular system. It can involve the respiratory system. It can also involve your vascular system. Okay. Sir was asking a question. In male patient, what will you specifically look for if it's going to affect the vascular compartment?
Sir, 3%.
That's what it. That's what.
Very often patients will get referred to urologist. So that is one feature you should keep in mind.
Sir, in my case, patient started on tablet hydroxyurea only, sir. So to start a drug imatinib, we planned for flow cytometry and fish studies. Sir. So patient is now on hydroxyurea.
How does imatinib act?
Sir,
how does imatinib act?
So it increases the apoptosis.
Huh?
It increases the apoptosis.
It increases the apoptosis.
Apoptosis.
It is a tyrosine kinase inhibitor. What is the longevity? What is the longevity if you put the patient imatinib? The patient is CML. What will be the lifespan?
Sir, 3 to 5 years.
Huh? 3 to 5 longevity for 3 to 5 years.
Yes, sir.
Can you tell me other newer derivatives of this tyrosine kinase inhibitors?
Other drugs, sir.
In that family, tyrosine kinase family, what are the other drugs?
Sir, dasatinib and dasatinib.
Then
dasatinib and nidaletinib.
Ninatinib. It's a tongue twister, probably you're not able to pronounce it properly. Huh? Yes. So any questions?
No, Mahesh, you need to just go back to your history Forget about myeloid leukemia.
Yes, sir.
Just you have a case of massive splenomegaly.
Yes, sir.
Just go through your history again, how to approach a case of massive splenomegaly, and ask questions pertaining to that. Okay. Forget about the diagnosis.
Okay, sir.
That's the only advice I want to give you.
Thanks.
Okay.
Thanks.
Mukesh,
Sir.
which is the first line therapy for your CML patient?
Sir, stem cell transplantation, sir.
Medications wise?
Medications wise, tyrosine kinase inhibitor, sir.
Tyrosine kinase inhibitors. Probably when you are starting discussing with the examiner, probably can think about the prioritization of your answers. It's applicable for your differential diagnosis also. The points more in favor of whatever your differential diagnosis, with minimal negative points, you put it in the first in order.
Okay, sir.
And everybody else, once again, coming to the same point, don't get biased with your or prefixed with your ideas of already known diagnosis. Don't go for it. As if you are seeing the patient first time, start thinking about, analyzing about the symptoms, and probably you can correlate with the clinical signs. As I think somebody was mentioning about, the examination is going to verify your symptom analysis. You anticipate, it is only anticipated examination. You anticipate this finding I'm expecting in this patient because it's this differential diagnosis. Something like that you think about and try to go for it, and don't get panicky. You're more of nervous also added to your problem of answering the questions. Even the simple questions you find it very difficult. Doesn't matter. Making mistakes is always, this forum is always acceptable, where you make yourself improve on the next presentation. That's the basic idea of having this type of platform. You make all your committing your mistakes so that you know where do you stand. It's easy for you to improve upon it. Okay. So don't feel very much bad about your presentation. You did your best, but there is a lot of improvement to be done for you. There's a lot of scope is there. Take all the comments from the examiners or the faculties so that you improve in the next presentation.
Okay,
Whatever
thank you.
comments passed by us is just to make you to fine tune yourself. That's all. Okay. Don't take it in any other sense. Okay. That's very important. And you said 92 for CML, the basically drug which you are using is nilotinib.
Yes, sir.
Dasatinib and nilotinib. Okay, nilotinib. Sir, anything else, sir? Namachivaim, sir, or Tanagar Mani, or not Arivarsan?
Oh.
I think we'll close the session. Is it?
Yeah. Yeah.
Thank you, doctor. Thank you, Dr. Saravanan sir, Dinagaran sir, and Arimani sir. Thank you so much for participating and amongst us for the past two hours. Thank you so much, sir. Dr. Muttumani. We'll meet again, sir. We have a discussion in the future. We'll again meet once. Thank you, sir. Thank you for the introduction.
Thank you, sir. Thank you. Good night.
Yes, yeah. Really thank every one of you for last 8 weeks. We had discussion from Trichy Medical College. Next week onwards, we're going to move from this Trichy to Madurai Medical College. Really immensely thank Dr. Manachayam sir for this wonderful discussion all this week. And really thank Dr. Muttumani also for this wonderful coordination. And thank you, Dinagaran Mani and Dr. Arivarasan. Thank you one and all. Good night.
Thank you. Good night, sir. Good night.
Good night.
Thank you. Thank you, Dr. Muttumani. 15 weeks.
Thank you, sir. Thank you, sir.
See you in the cinema.